And hello again, everyone. TJ Alt, I-45 now. And as it's been a while since we've seen him, but Dr. Philip Keiser, the now the interim director of the Galveston County Health District and CEO of Coastal Health and Wellness, as well as our local health authority. I mean, how many titles are you carrying around with you now, Dr. Keiser?
Too many.
Too many, right? So as we had said when all those things had changed up, that we wouldn't always be on every week, but we've got a lot of news happening on the COVID front, and we do want to follow up on that. And he joins us here again. And Dr. Keiser, right off the bat, let's get in. The kind of the bigger news right now is when and which booster shots will people need on this? Because we're starting to look ahead now.
Right.
When are booster shots possibly going to be needed on the vaccination for COVID-19?
Yeah, it's a good question, and we don't know the answer to that yet. There's a couple things that are coming down the pike about that. The first thing is that there's so many of these variants now that the WHO, the World Health Organization, has changed their nomenclature. So instead of all these complicated numbers, they're giving them Greek letters and alpha, beta, gamma. And what this will allow people to do is to basically group the different variants together instead of having a separate one, and then start to follow how they're going to react. So right now in Galveston County, our single highest variant is the British variant, the UK variant, which I haven't learned all the Greek letters yet, so I'll start working on that. But after that, we're starting to see the Indian variant in Galveston County. We've had over 10% of our isolates are the Indian variant. So the real question is, one, which is the dominant variant? And then secondly, does that variant escape the vaccines? And so there's a lot of epidemiologic work going on right now, as well as work to try and redesign the vaccines so they cover the common mutations that are occurring. So that's the first thing. So they've got to come up with the right vaccine for the right variant, and time will tell which one that is. The second thing is that will we need a booster shot? And there's a lot of debate right now as to whether we're going to need a booster shot or not. So far, we're getting data out for 9 months, and people are still doing okay. The people that were in those first studies were, going 9-10 months ago, and not having any problems and not getting infected. And so we'll see whether we actually do need to get a booster shot come fall. But if we do, we'll be ready for it, and we'll be ready to roll it out just like we did before.
We'll talk a little bit more about that, as well as, if you should be an annual shot as well, to be talking about should you get your shot again the same time, or should it go like a flu season shot? We'll talk about that when we come back after this word from Coastal Health and Wellness.
Hi, I'm Christina Garcia. I'm the Patient Services Manager at Coastal Health and Wellness. I want all Galveston County residents to know that the open enrollment for the healthcare insurance marketplace is now. At Coastal Health and Wellness, we understand the importance of having access to high quality health care. And we understand that the application process can sometimes be stressful, trying to figure out which plan is best for you and your family. So we have certified application counselors that are waiting to walk you through the process. There are 4 categories of plans to choose from, and our counselors will help you through the process. All the plans will cover essential health benefits, pre-existing conditions, as well as preventive care. So what do you need to know, Galveston County residents? The time to act is now. If you need assistance or if you have questions, call us. At Coastal Health and Wellness, we're here to help you.
And it's something we say each time we do this show too. While we talk about COVID a lot, don't forget about the rest of your health care that you need to do. And in fact, one of the things I think we need to be talking about on that is along the lines of, I was talking with a UTMB general practitioner not recently, and he was explaining to me it's getting scary how many of his patients are not checking in as regularly as they did before. Right. You've seen that as well. How much of a concern should we have about that? Get away from just talking about COVID right now, but other that should be, acute illnesses that turn into chronic because someone hasn't gone to the doctor or followed them.
Yeah, no, it's a big issue, and we've certainly seen a lot of our patients who haven't done their follow-up. I saw somebody on Wednesday last week who hadn't been seen since 2019 and hadn't had any labs drawn in 2019. And I think there are a lot of people like that out there who, they may not have COVID, but they may have diabetes, they may have HIV, God forbid they have cancer, may have high blood pressure, and they need to go see their doctors regularly. So now's the time to do it. Clinics are opening up. We're trying to get rid of as many of the restrictions as we can to make it so that people can easily get in to see their doctors. And it's really, really important. There are some people who haven't gone because they were afraid of getting COVID. There's some people who haven't gone because there was a time that we closed clinics down and only did telemedicine visits. And there are some people who, stuff has happened. They've lost their insurance. Some other things have happened. And so, things like, signing up for health benefits, coming to Coastal Health and Wellness if you don't have the money to pay for your health care. These are all really, really important things, because I think when this is all said and done, we're going to find a lot of what we call excess deaths with people who died not just from COVID, but also died because they weren't taking care of themselves.
Yeah. Yeah, this doctor he was very, very, very concerned, and he actually a pediatrician, and he was that was what was really worrying him, was that what we talk about for children in related to COVID, that yes, they're less likely to get the infections, they're more I don't want to say immune, but can resist the infections from there. He said, but they're not resistant to everything else, and he's really, really, really concerned that on the school year we're going to have a lot of sick kids because they haven't been coming to their doctor just for the regular stuff.
Right.
Again, not talking about COVID.
Right. No, I think that's absolutely true. And the thing is with kids, it's not just one kid, it's families, right? So it's multiple kids, and because of all of the problems we've been seeing, that they may not be getting in and getting to see their doctors, and they may not be getting to see getting their vaccines. And that's why now, as we're moving along throughout the summer, what we're doing is we aren't just doing COVID vaccinations. We're trying to combine that with health fairs. And when it comes time for schools to start up again, we're going to be combining things like, back to school physicals, sports physicals, get your COVID vaccine, get your other vaccines. Let's get you hooked up with a pediatrician.
Yeah, and it's something that I think a lot of folks need to pay attention to. And again, as Dr. Keiser had mentioned, if you did lose out on your health care, whether you lost a job or you have a reduction in benefits or something like that happened from there, Coastal Health and Wellness can set you up, and we have that information on our site, as you saw there, where you can find out more. You can go to Galveston County Health District, or actually go to the Coastal Health and Wellness website to find out some more. You can get enrolled. I've already directed several people there in the last few months because they thought they'd missed out, quite frankly. And then they happened to watch us one day and realized, oh no, I got till August 15th, and they all called.
Right. Everything's been extended. Yeah.
So again, you till have August 15th to get that, so you can get insurance coverage in there. So the other one, cruise ships, big talk. I think that's the biggest thing that you and I get talking wise is talking about cruise ships. When are they going to go? And you've been looking over at all those plans and everything else that everyone has. So I'll put it in there with you now. What are we going to be seeing here?
Well, so it looks like Carnival's is going full steam ahead to start cruising on July 3rd. And, we've been working very hard to get all of their crews vaccinated. We're also working hard to get crews from freighters vaccinated because, they come into our community as well. So we're working very hard with the port to make sure that that's a very, very safe place. I think that's the first thing. The second thing is Royal Caribbean looks like it's going to be August 3rd. So a month later than Carnival July 3rd, August 3rd for Royal Caribbean. Both of them are following similar type of plans where they're not requiring that everyone be vaccinated to get on board. CDC gave options to do it one way or the other. But in order to get on board the ship, if you're not vaccinated and you can't present documentation that you be vaccinated, you have to go through screening. You have to demonstrate that you have a negative COVID test within 72 hours. And if you don't have one, they'll test you right then and there. They're actually going to be setting up to do the testing. We're expecting both cruise lines to do what are called test cruises, and that's where volunteers get picked to actually go through the process and then go out and do a short cruise and then come back. And it's an opportunity to test all of the processes. Now, everybody's asking me, how can I get on that cruise?
Yeah,
The answer is,
that's the
I
second most
don't
asked
know.
question. Yeah, right.
I'm the wrong guy to ask. And I got to tell you, no one from Carnival or Royal Caribbean has asked me to be on the test cruise. So I don't know, but I know they have lists of volunteers, and you can sign up on their website. And you might get lucky, you might get chosen to be one of those people and get a free cruise out of it. So that's where we are right now. I'm pretty optimistic about this going forward, and with all the safeguards, particularly the fact that they're working very hard to vaccinate 100% of their crew. I think it's going to be a pretty safe environment, and people can feel pretty confident as they resume going back to cruising.
And that may be a key thing to talk about too, is the fact that on the crew vaccinations that are taking place, is that we were there that day when Carnival, Christine Duffy from Carnival came down. You were there, Dr. Ben Raymer also there with us that day of the big important announcement that they were trying to make, but that the crews were getting vaccinated that day as well, as you're taking a look at it here. And what Christine Duffy, the president of Carnival, was telling us that that their crew members, they're telling them they've all agreed to it, like 100% on every one of their ships, to get it done.
Yeah, CDC's requirement's 98%, or that's their target, but we're seeing almost everybody's getting vaccinated. And, so these folks are flying in internationally to get on board these ships. And what we're finding is about half of them have been vaccinated already, or at least have gotten their first dose of the vaccine. And so it's very heartening to see that everybody is, wanting to get back to work and recognizes that they need a vaccine, but also recognizing that the vaccine is safe and effective and it's there to protect them. And, if you think about it, what makes a cruise ship dangerous? Having a bunch of people crammed together for a very, very long period of time. That's both passengers and crew. And so the people that go for more than 4 or 5 days, that's the crew members. And so by having crew members vaccinated, that's the best protection I think people can have. And then trying to sort everybody else out and make sure that somebody accidentally doesn't get in with COVID. And, the length of the cruise is going to be, even 7 days means that even if you had COVID and you got diagnosed the day after you get on, because if you have it, they're not going to let you on. The day after you get on, they're going to quarantine you, and the chance that it transmits to somebody else is going to be very, very small.
On that too, you'd said that they're going to have, you're going to have to prove that you've been tested in the last 72 hours. You've taken a look at these plans. And I've gotten this question a lot. Folks have asked, is it okay? Am I going to require it? What type of test do I have to be able to show? Yes, I've tested negative. And do they have to have a particular, like the PCR test, which is
it's probably So the testing that's going to be done at the point of care as they come in will be the antigen test. But still, these are tests that are still invasive. So I know everybody's asking, is there a way that I can get away without having that stuck up my nose? And the answer is no.
Nope.
No. You want to go on a cruise? You got to go for it. I've had 6 or 7 of them now, and I fully get it. And I've had a few that were basically grab the chair and kick my feet up in the air as they were digging into my brain. But, so it is uncomfortable, right? But it's not harmful. And I think it's a small trade-off to be able to, go and have a good time. But also it's a small trade-off for what this is going to do for our economy here.
And I should, and I'm matter of fact, a group of us, some friends, my wife, and we're all heading out July 15th. We're taking a shorter cruise after everything else that opened up, and we're waiting to hear back from the cruise lines about how things are going to go, because there's still test cruises and as you said, need to go. What can folks, from what you've seen, expect once they're on board? Are there going to be mask requirements?
So masks on board in common areas. And not having to mask when you're in your room or in private places, I think is the general rule of thumb we're seeing. Now, a lot of this is going to depend on what the test cruises look like. Celebrity did a test cruise this weekend, but only with fully vaccinated people. So we'll see how that goes. And of course, we don't expect to have any problems with that. But once you start getting people that have not been vaccinated, that's where all the logistical questions really start getting complicated. And we'll see how well those systems work. And don't be surprised if a cruise or two goes out and then the rules change because of things that were learned during that period of time that the tests were going on.
And then what for folks that go, but when you say in the common areas, I just had someone text me personally on this when they heard you just say that, saying, what does that mean at the pool? I'm going to have to wear a mask.
I don't know all the details about any specific place, right? And so the stuff we saw basically said, in the common areas that people will do it. So a lot of that's going to be depending on board the ship. And remember, when you're on board the ship, they call the shots, right?
Yeah.
And so, it's like when we got off a plane from going to Mexico, we were still in the secured area, and some guy wanted to take his mask off, and he goes, "Well, this is Texas. I don't have to wear a mask." And it's sort of like, well, you're still under custom border control,
right?
So you got to do what they tell you. So so they're going to call the shots, and they're going to take the most safe pathway as possible until we have better information that they don't have to do it. So, if you're going out there early in July, expect to be wearing a mask most of the time you're on board the ship. All right. That's just kind of the way it's going to be. And there may be places that they don't make you wear it, and great, that's fine. But that's going to be up to them, and we'll see how it works out.
Let's get some of our viewer comments. Again, if you have a question, you can comment in the comment section, either on our Facebook pages, or YouTube, or on Twitter as well. And Leanne Palumbo did this through our YouTube channel. Of the vaccinated people who have gotten COVID, these are the breakthrough cases, which are still pretty rare, but how many are ill enough to have been hospitalized? We've talked about this the last time you came on the air with us.
Yeah, so I haven't seen the latest figures right now, but I can tell you that I'm not aware of any person in Galveston County who's been fully vaccinated and got COVID and then was hospitalized. The hospitalization in fully vaccinated people happens so rarely, it's worthy of national news. And so it's a very, very unusual event. So far, so good. Not a big problem.
And in fact, wasn't that the part of what we talked about a lot in the vaccination effort, by the way, is that no vaccine is going to be 100% effective from preventing this. I mean, it doesn't exist on Earth, but it does lessen the effect should you get sick again. Yeah. And that's been the bigger part of the message. I think sometimes that's gotten lost. Yeah. We hear vaccine and we mean that's going to prevent. Actually, it lessens, I guess. Yeah. The difference between waterproof and water resistant, as I tell folks sometimes.
Yeah, that's a good analogy, I think. But 90% of the people that get the vaccine overall, don't get infected. And even in the ones that do get infected, we're only talking about 5% that get some sort of serious illness. And so these vaccines have so far performed much, much better than expected. So just think about a flu vaccine. If we get 50% effectiveness in a flu vaccine, we're happy. I mean, these are 90%. Oh my God! We've never seen anything like this with a vaccine before, and they're holding up. And so, there are people that are going to get infected, and of those people that get infected, most of them are going to have minor illness. A small portion will be asymptomatic. And here's the other good news: is that those people are not likely to transmit the virus. So it's a very positive thing. That doesn't mean nobody anywhere is going to get sick. We know that there are, and if we go long enough, there are going to be people in our community who get sick, but they're going to be very, very unusual cases.
And the part about transmission was the thing that interests me a lot, just personally in this, because I find that fascinating. Because a lot of times when you talk about vaccines, it's about just lessening the effect on you.
Right.
Not so much that you're not that it's yes, it'll lessen the chance of you shedding the virus on someone. Yeah. And early on, we're talking about the vaccine. It doesn't mean you can't shed the virus, but research is actually showing that it's preventing that as well. Correct?
Right. It's preventing shedding the virus, and it's also preventing shedding the virus in enough quantity so that it can infect other people. So there's a basic principle that in infectious diseases, something we call an infectious dose. How much of a particular bug do you need to get in order to get an infection? And it varies depending on what the various bugs are, and viruses, bacteria, it really doesn't matter, but it varies dependent on the different species. And, if you think about it, this vaccine keeps people, one, from getting infected, but when it does get infected, it keeps you from getting sick. So what that means is you have less virus in you, which means you have less virus coming out of your nose, which is less virus to then spread around to someone else. So in those cases, it shouldn't surprise us that vaccinated people are much less likely to spread the virus.
For those of you just joining us, Dr. Philip Keiser, the local health authority for Galveston County, also the interim director of the Galveston County Health District and the CEO of Coastal Health and Wellness, joining us here today. Question now from our viewer, John Bowen, did this through our Facebook page. He says, what's the science of antibodies that were acquired from actually getting COVID? Why would that be different from any other virus out there? We know there's been this has been politicized in many ways too. Some folks said, well, I've already had the virus, I don't need to get the vaccine. But what is the exact science that we're looking at that? How protected are you? I like it too. We always heard about measles or mumps. If you had the measles, you never had to worry about getting the measles again. Oh, sorry, you have to wave here.
There we go. Sorry.
In fact, we had this conversation. Okay, just so our viewers are a little behind the scenes, we had this conversation before we came on the air that there's someone supposed to be in the office coming in and waving in your office to make sure the lights don't go off because he's got one of those energy saver things. So, and it caught us. We knew that was going to happen at some point. Anyway, but again, back to what that is, talking about that is that COVID, obviously, being a coronavirus is not something that that goes away once you've had it. It's going to come back at some point, and you could be lessened. So let's just first talk. If you've had COVID-19, are you protected for a year, 9 months, 6 months before you need to get vaccinated? Maybe, or are you more protected? How does that work?
Yeah, so let's talk a little bit about antibodies, first of all, what they actually are. So basically, an antibody is a protein that reacts to a part of the virus to neutralize it. So if this is the virus, an antibody comes in like this and grabs it, and then your body's able to clear it and get the virus out. Now, for COVID in itself, it's a big glob, and so your body makes an antibody to this, this big glob right there. But unfortunately, some of these antibodies grab here, some of them grab here, some of them grab here, so they don't necessarily get a good piece of it. And so what happens with vaccines is they take a very specific part of the virus that it can grab hold of, and that it keeps you from infecting other people. And so that part of it is called the spike protein. It's called a spike because it looks like a spike and it sticks up. And so the antibody comes from the vaccine and binds onto that, and then it can't infect other things and it goes away. So these are like fingerprints, and every mutation we have on the virus, on that spike protein, is like having a slight variation in the fingerprint. And so if it varies enough, then the antibody won't be able to grab onto it. It just won't be able to do that. So when we talk about antibodies from the vaccine, we're talking about a very specific one. When we're talking about antibodies from a natural infection, it's antibodies to a whole bunch of things. And unfortunately, it's not necessarily enough to that one particular spot to guarantee that it will prevent infection. So what do we know? We know that if you've been infected with COVID, if you're under 50, 6 months later, you'll still have some detectable levels of antibody. If you're over 50, maybe not. It tends to go away. But what we really don't know is just because we don't detect it in the bloodstream, does that mean you have no protection even through natural immunity? And initially, because of what was seen with other coronaviruses, particularly the ones that cause colds, where people get colds year after year after year after year, it was assumed that, well, you don't make antibodies to it, and people have tried to make cold virus vaccines, and they didn't work very well, that your natural immunity would go away. It's interesting with COVID, we're not seeing a lot of people who get infected a second time getting sick. Or getting really sick, let's put it that way, getting up in the hospital. And so, I think the question is still open on how long this will last and how effective this will be. And as time goes on, as we get opportunity to study more people for longer periods of time, we'll have a much better sense of what happens if you were vaccinated, what happens if you got natural immunity, and how long does that protect you. So it's still very much an open question, in my opinion.
John, thanks for that question. That was a really good one, and I like the explanation. We're going to have to get you your own little coronavirus
There you go.
COVID model. When you were doing that, I was trying to find an actual video we had of that, and the first thing that popped up when we had the cake that had the coronavirus on it.
Yeah.
I didn't think that would be an appropriate way to display what we had on going on for that right now. So that's to go on. That brings up my next question here: is that what should we be doing to protect ourselves from the next virus? We've been talking about this one for more than a year now. Yeah. There's going to be something else down the line. What should we be doing right now to help ourselves out?
Well, I think the most important thing is to work on the infrastructure and all the lessons learned from COVID. You see stuff on 60 Minutes. Did something happen in Wuhan? Was it a lab accident? Did it come from bats or other places? So we need to really be looking at strengthening our entire spectrum of public health, meaning that being able to detect these viruses as they're starting to emerge faster, but also building the systems in place to be able to respond to them. We spent an inordinate amount of time just setting up a data system. That dashboard that you see, that took a couple months for us to develop, to have all the data flowing in. We need to make sure that our public health is well funded, so we have people that can do contact tracing and can help people get vaccinated if need be. And then I think one of the other lessons we need to learn is that hand hygiene and masks, I should say, actually work in preventing infection. And so as we start going into other types of flu season and other types of things, we need to go back to that. And quite frankly, if we start having a bad flu year come the fall, we're going to be telling people, if you're in danger of getting sick from flu or have something bad happen from flu, get vaccinated, but wear a mask too. So, I think we're going to keep seeing these themes coming back over and over again.
Well, and you brave about the hand washing. That is, if there's been one thing that's been consistent from day one talking about this, it is wash your hands, don't touch your face. Yep. Careful when you're shaking hands with people, but at least wash it. That's been the one thing that's been around since day one. And by the way, we should point out, you also bring that up every single time. Do you need to wave again? I see you're looking at the door.
No. Someone came in and waved.
Someone came in and waved for you. And for those who are just joining us on this, that Dr. Keiser is in his office that has one of those sensors that that if there's not a lot of movement in the office, the lights go off, and so we have someone who's designated to walk in and just wave at the light every once in a while. But getting back to what I was saying is that you're saying wash your hands, and it gets into, if we have a shortage of this again, hand sanitizer it works, but soap and water is just as effective. Correct?
Yep, that's correct. That is absolutely correct. And but one of the things we've learned from COVID, if you're willing to do without your whiskey, we can convert those distilleries into hand sanitizing factories very quickly.
Yeah, I think we're gonna have a lot of folks already saying that.
I think so
stop doing that now. You brought up something about that CBS report, and it's been getting a lot of the new there. And I want to talk about the real origins of COVID-19. Yeah. Had a conversation with someone earlier today. He said, "Well, what's the big deal? What do we care?" It actually does matter more than just trying to, you're responsible type thing.
Right.
It does help down the line. Prevention, for example, what we just talked about. Can you talk about that? Because I do remember attending the first town hall we did with UTMB last summer on this, and I think there's a difference between what you're hearing experts say and what we were hearing talking heads say in media. Mm-hmm. I was not hearing scientists a year ago dismiss totally that there was possibly a lab origination. They were saying it was less likely. That was the term used, and it was more likely a natural occurrence, but that was still being looked at. Can you talk about that? Because that has made, to the point that President Biden has said, I want another review of this, and a closer review. Can you talk about that?
Yeah. So I guess there are two questions about, did it come from a lab? The first one is, did someone make it in a lab and through genetic engineering? And I think most people believe no. It looks too much like a wild type virus, and it looks too much like something that quote unquote occurred naturally. Does that mean that it didn't escape into the population through a lab? Well, that's really possible. So remember, that Wuhan lab was set up to study viruses and to sort of be a sentinel for virus. So they have people who go out and who collect specimens, and then they bring them back into the lab, and then they grow them up in the lab. And within that, it's entirely possible, although we have no data that will prove it, that perhaps someone doing that got infected accidentally. And if they got infected accidentally, could have taken it out into the community and could have spread it to other people. And that's the question that's being investigated right now. And so the value in this really lies in, if we are going to be vigilant against finding new viruses and making sure that they don't have adverse effects, that in the process of looking for them, that we don't accidentally spread them to other people. And I think that's the pertinent question at this time.
Yeah, and it goes into, I was reading a fascinating article, to me anyway, I should point out, about gain of function, which is that kind of coding. Can you explain what that is, so folks, because the way I kind of liked it is that it's a way, actually, when you're dealing with scientists or researchers are dealing with a virus, they're able to do it so they can find the protein spike a little bit easier. Yeah. And that's what's done in the lab. Right. And that gain of function, and it helps them identify that spike faster. Right. Yeah. But at the same time, it does change up the genetic code a little bit. Can you talk about it? Because that's been getting a lot of talk.
Right. So the idea behind that is that if I have a virus and I want to understand what about this virus makes it so deadly. So let's go back and look at 100 years ago, the 1918 flu epidemic. Clearly, there was something very different about that virus. And so what researchers had done with that virus in the later part of the 20th century was to, one, see what that virus is, look at the specific genetics of the virus, see how that different from the flu viruses that we had in our own community at the time, and then actually make small mutations in the genetic codes of the virus that wasn't as pathogenic to see if they could make it more like the one that was so dangerous. And then they go, aha, this is the spot. This is the particular mutation. Why is that important? Because we get flu every year, and if we start seeing flu with genetic mutations that mirror what we saw in the 1918 epidemic, that tells us something bad's going to happen. It also helps with identifying ways to block it, whether that be drugs. Okay, if I have a drug that blocks it at this point, it will then help prevent the mutation, or it will help prevent the virus from being so pathogenic, and also helps with the vaccine development. So that's why all of these things are done. And these experiments are done in ways that they're never meant to intended to ever leave a test tube. And those are some of the things that people are talking about with this idea of gain of function.
And on that, though, is that they're not supposed to, but let me just go into my James Patterson mode. If people don't know, sure. James Patterson, who would go down this right, because I heard him actually kind of bring up the question this way. But yes, it's done in research, but could someone with ill intent say, I'm going to do this so I can make this virus,
of course,
spread faster?
Of course, and in history, people have done that. There were biological weapons programs that took place in both Europe and in Asia during World War II, and then both the Soviet Union and the United States had biological weapons programs where they could potentially weaponize things. And then, of course, there's the very famous case of the anthrax outbreak, where someone took a bacteria, not a virus, and genetically engineered it. Not only did they genetically engineer it, they then took it and literally polished it to make it so it would be much more easy to infect and get up into an airborne, so it would infect people. And there were people that died with that. And the FBI finally thinks they figured out who did it. And he was a scientist who ultimately took his own life. So can people use these things for malintent? Absolutely. That's why we have these types of labs like we have at Galveston. There's only like 3 of these labs in the United States. The former Soviet Union has one, the WHO has one, and they keep these things under tight lock and key with armed guards who will shoot you if you try and break into them, because these things are that dangerous and they need to be carefully studied and carefully preserved. And why do we need to keep smallpox around? Well, because if somehow it gets loose or if it comes back on its own, we need to be able to respond and develop new vaccines and new ways of stopping it.
Yeah, and that's one of the reasons it comes up. There's some dangerous stuff that's still contained somewhere, just in case it comes back in some form,
That's right.
whether man-made or not man-made, but man-distributed or animal-distributed. Mm-hmm. But Lowen, what you do know in dealing with the infectious disease experts that you do, what is the most I would say most reasonable assumption of how COVID-19 spread as fast as it did worldwide? Because that's the thing I think a lot of folks, when we talked about SARS many years ago, we saw it in pockets. We didn't see this worldwide pandemic set up. And it's not like travel is much different today than it was then. Yeah. I just wonder, from what you're hearing from infectious disease experts, and that's your background too, of where the likelihood that this was a possible human transmission to start. As you said, maybe a scientist had walked out and infected didn't know it.
Yeah, so it's hard to know exactly where it started, and I'm of the opinion that we'll never know. I think it's so far remote that even if the WHO and all of our best scientists and the FBI and MI6 and the KGB all had access to those records, which we know aren't going to happen, that they probably won't be able to figure it out. I think it's too much has happened and too much time has gone by to pinpoint it exactly. But it could have very well have happened in one of these markets, one of these meat markets, and someone got it. And the thing is that this particular virus hit the sweet spot. So viruses like Ebola, which are very, very infectious and cause people to bleed everywhere, and then there's blood everywhere, and people around it, they get even little bits of blood, they get sick, and they die very, very quickly. Well, because they die quickly, it tends to lend itself toward outbreaks. You see it come up, and then it kind of dissipates. Everybody runs, and people quickly develop a natural quarantine zone around that. Now, in Africa recently, it got into some cities, and if you've ever been to these cities, you'll see why it was so hard to get rid of, because they're just so crowded and people literally living on top of each other that they wouldn't be able to get away. It'll just kind of keep sputtering along, but even then it tends to die out. SARS, same way, had a pretty high death rate. 50 to 80% of the people that got it died. COVID, look at it, it runs from as asymptomatic infection to most people having, I feel bad, but nothing terrible, to 10 to 15% of the people get sick enough to get in the hospital. And of those people get sick in the hospital, half of them get sick enough to be in the ICU, and about half of them die. So it spreads such a wide group. It really hits the sweet spot. So what it does, it allows the virus to spread much, much more rapidly and much more easily. And then it happened to go in Wuhan, and I'd really not heard of Wuhan until this all started, but apparently Wuhan is in the center of the country. It's like in St. Louis, and there was an airport hub there, and anybody who wanted to go anywhere in China transferred through Wuhan. Well, what a perfect place to have something like that start. And it just spread very, very rapidly around the world, initially on airplanes, and we know it spread on airplanes. And so by the time that you got done your 8-hour flight from, Wuhan to Europe or Wuhan to the United States or Australia, you may have already been infected, and then may have been infected and not even known it, and never got symptomatic, and went home and gave it to your family. A couple of them got sick, but not too bad. I got a bug, and someone else gives it to somebody else, gives it to somebody at work, or takes it home to their grandparent, and their grandparent dies. And that's how I think this thing spread so quickly and so rapidly.
Going now to kind of a next time, we talk about vaccines and how it spread rapidly, but also the vaccines again. Moderna announced last week it's going to go for full authorization instead of emergency authorization.
Yep.
That's a big step there. I will say this, as much as we watched Moderna and Pfizer go back and forth on this, I was ready for Pfizer's announcement to come out an hour later, the way those two companies have been going at it. How is that different now? What research they have to do now to go for full? I mean, essentially, they've got millions of people who have been in clinical trials to show it works out there. But what's different now that they've gone for the full versus what they did for the emergency? Can you explain that?
Yeah. So the emergency use, remember that what they did was they did everything in parallel sequences, right? Getting all this stuff. Now they've got a whole bunch of what we call phase 3 trials, and these are the trials that are the efficacy trials, so you have them in adults, you have them in people over 65, you have them in kids 12 to 16. There's ongoing studies from kids up to 5 to 17. There's studies ongoing with infants, pregnant women. All of these things now are being put together and having hard endpoints. From sort of a common sense point of view, we've seen plenty of data to show that overall these things are safe. There still are concerns, right? In teenage boys, very rare cases of myocarditis. The adenovirus, the J&J, and also the AstraZeneca virus, associated with some blood clots. And so what they're going to do now is they're going to put all this data with all the subgroups together, and they're going to apply formally for approval. And then what the FDA does is they look at a variety of things. They look at safety, primarily. That's the number one thing. Is it safe? And by safe, we mean that the benefit outweighs the risk. And it'll be looked at in all of those subgroups. So for every boy with myocarditis, we're going to see how many tens, hundreds, thousands of boys who didn't get it. And is it just something that happens very rarely, or is it something that happens enough that maybe that's not a good idea for this vaccine in that group of people? And then they'll look at the efficacy, and efficacy will be how many people die, how many people get hospitalized, how many people get sick. And obviously, the younger you go, the less likely people are to have to get sick. So that's really going to focus on the safety side, on are we making kids who are less likely to have a serious effect from COVID more likely to have a side effect from something else. That's going to be the real question as far as I see it. And then the other bigger question is that by vaccinating these kids, how is that affecting older people around them? So they got a big job ahead of them. Fortunately, they're going to have more data than I think any other application that has ever been put to the FDA, because of the fact that we've had the opportunity to use this in so many people before it gets the final approval.
Gotcha. And I have, my friend, this has popped up. I want to bring up a question on that, because I'm not sure I didn't even know the answer on this. Either Dave Culp asked this: why did the animal trials get skipped with the mRNA vaccine? Were they skipped, or was that like kind of early on and then it went? Because like you said, everything was in parallel.
Yeah, they did some animal safety trials, but one of the other things is that they like to see with drugs anyway, and is to have some sort of animal model. So for influenza, we can do that, right? But there really is no good animal model at the time that these things were being developed for COVID. We didn't know, can we give it to ferrets? Do we have ferrets to give it to? Can we give it to guinea pigs? Can we give it to rats? All of those sorts of things. Will they get infected? Will they get sick? Will they get sick in the same way people get sick? And so it takes a long time to develop all of those things. So that's part of the reason why we don't see some of the animal toxicity data that we usually see.
Gotcha. Dave also asked this question. It said, isn't a strong immune system better than a vaccine? Than the vaccine, I should say.
Well, a vaccinated strong immune system is better than a strong immune system. So,
I figured that was going to be the answer. I just thought it would answer it. It's not an either or thing, but there are concerns about people have general concerns about vaccinations, about getting any shot in your arm.
Right.
There, I thought that was kind of one to kind of point out. As we go into our final minutes here, I wanted to kind of bring up, because we are in just over this weekend celebrated I shouldn't have said that. Sorry, marked the 40 years of HIV since the first cases. Folks may not know of your background. That's when you got an infectious disease. That's what you were working in.
That's right.
Was in
HIV.
That's right. And again, forgive me for saying celebrate. folks. That was just really wrong. I'm used to saying some term like that, and that's just wrong. But reflecting back on that 40 years, there's been a lot of progress with HIV, but there's still, and I bring this up in the kind of the COVID experience here, is that we've seen so much jump with vaccines for COVID, but here four decades later, and there's not a HIV vaccine. And I just wonder if you could talk about that, since that's an area you have worked in, most of your career.
I remember 1983, I was a medical student. I was a second-year medical student. I went out with some friends. I ate something, and I had food poisoning, and I spent the night puking. And the next morning, I stayed home, and I'm watching TV, and there on TV is a news report. Margaret Heckler, the Secretary of Health and Human Services, with Dr. Robert Gallo, announcing they had found the causative agent of HIV, and we could expect a vaccine in several years and a test in several months. Well, it took about a year and a half to get the test done, and we still don't have a good vaccine. All right.
Yeah.
And so when everyone was talking about developing a COVID vaccine in months, I was very skeptical. I'll be very honest with you, because my experience is that this is a lot harder than anybody thinks. But I think the most important thing is that viruses are different. Each virus is different, and each epidemic and pandemic is very, very different. And so the technology that people have tried to apply to get an HIV vaccine really has not been effective. It's been an abject failure. We really don't have much to show for literally hundreds of millions of dollars and millions of lives in terms of developing a vaccine. And then COVID came along, and people were talking about, well, based on what we know about the other coronavirus, this is the way it's going to behave. Okay, and we made a lot of mistakes with that kind of talk. But what I think it shows is that the vaccines are different. But for me, it also gives me hope in thinking that, wow, maybe mRNA vaccines will change the way we do with HIV. And so HIV has gotten a lot easier to treat. We can give people one pill once a day, and they can expect to live long lives and not suffer from HIV. And I don't take umbrage at the word celebrate. I celebrate the lives of my patients who have gone. And some wonderful people and some people I miss. I hope we can get to the point where we can actually, just as our kids start coming up, we can give them a COVID shot, we can give them an HIV shot, and we don't have to worry about this stuff anymore.
I also wanted to kind of bring this up because it's for those who don't know the stats. In those 40 years, 32 million people died worldwide.
Right.
Right now, there are 38 million people living with HIV.
Right.
I've that number, and this is straight from the CDC data and the HIV research data on this. It is interesting to look at, but I also remember the early days of talking about HIV. It became from, can you get it from sitting on a toilet seat to everything else, and also, and for folks who watch us on a regular basis, know my aunt is. Works for UTMB, and she's a medical ethicist, and that's basically is how you deal with the ethics of the medical side of things. And early on in her career, she worked in HIV as well. Mm-hmm. And I met a lot of folks who were talking about their personal stories of dealing with doctors, dealing with nurses, dealing with the general public, and how just the stigma of that prevented a lot of things that maybe should stress gotten us further along. And so and like you said, and of that, that the folks that have lived with it, and we have come a long way. I say as a society, in battling this deadly virus. I mean, but again, to remark it, of everyone is different. Every one of these viruses is different.
Yeah.
This one that has been different from the get-go as well, and COVID's different as well.
Yeah, there's still a lot of stigma around HIV, although it's certainly gotten a lot better. I remember, there were a lot of people that were senior to me and people that I looked up to who didn't want to take care of HIV patients. And basically, this was my generation, we were a bunch of young doctors, and we didn't think it was right, and we ended up taking care of a lot of people with HIV simply because no one else would do it. No one else wanted them, and some people even wanted them to die, and it was pretty awful, and an awful lot of them did. And we've certainly come a very long way, both in our treatment. I remember telling someone many years ago, what I did, and the response was, "Oh, bless your heart." And I was, I first arrived in Texas, so that was my introduction to that comment and the various meanings of it. But we've gone a long way, and there's no reason in America why anyone needs to die from HIV anymore, because the medicines are easy, they're easily accessible, and they work extremely well. But as I'm getting older and thinking about what's the end of my career look like, it'd be nice to cure somebody from HIV or vaccinate somebody for HIV before I retire. So
and there was a big push to be able to say it's time to end the HIV epidemic.
That's right.
Out there, and I know there's a lot of research, and someone in the comments said, "Well, I've been seeing all these commercials about folks being able to take medicine now and live with it." I said, I never expected to see that even.
Yeah.
Like you said, though. But then there's the flip side of that coin. What year was it you heard it said, okay, we've had this breakthrough and we'll have a vaccine within a couple of years? 1983.
1983, April.
Yeah.
1983.
Yeah. 2021, and that still hasn't gotten progressed that way. We appreciate you as always, Dr. Keiser. As I said, I wanted to make sure we ended on that note, knowing how much research and how much work you had done in the HIV world over the decades, and we didn't want to get lost on that as well. It was, we have learned there are a lot of lessons learned. There's all lessons that we forget, I think, sometimes too. As you saw, the stigma is still there on HIV, but also as we see things, and he's not waving at all, y'all folks. Again, where is he? She's supposed to be in there waving at your light for you. Anyway, so I appreciate it, and also I noticed since we had yesterday was D-Day, I see you have your poppy on. On there for those that don't who may have been remarking, that's not a big fashion statement actually. Remarks back to D-Day is a big thing about having poppies, and a lot of folks in this generation don't know about those. In fact, I find it hard. It used to be you'd go to any VFW hall and they'd have them there.
Really?
And they hadn't seen those in a while. So, Dr. Keiser, thanks for coming on with us again. We appreciate it as always. And again, if you have any other questions, you can send them to us. We'll bring those topics up when we come back on again. It is summertime. We're going to try to keep these. We are going to morph this a little bit more as we go. We'll always, have some about COVID, but we're going to start talking about other health subjects with you to make sure folks out, as you heard us talk about in the beginning of the show, folks not seeing their regular doctors on a regular basis. And we're going to be focusing a lot on that as well. So make sure you tune in with us on that. So Dr. Philip Keiser, the local health authority for Galveston County, thanks again, as always, for coming on with us. We appreciate it. And thank you, viewers, for your questions and your comments. Keep them coming.